non-secretory, or plasma cell leukemia, and I'll go through the definitions of each of those as we go along. But really, the distinction needs to be made between plasma cell myeloma and a multiple myeloma, and that is based on a combination of clinical features and morphological features. A lot of people don't really make that distinction, but certainly within a morphological practice, that distinction is important. Finally, I'll touch very briefly just to mention really the POEM syndromes. This is a clinical correlation, and the role of the histopathologist or hematopathologist who reviewing bone marrows is really just to give the plasma cell features within the marrow that can be associated with other clinical features to make those various neoplastic paraneoplastic syndrome correlations. So starting off with the monoclonal gammopathies of uncertain significance, you can either have IgM monoclonal gammopathy or non-IgM. So the IgM stands out as a specific group. It's just 20% of all the monoclonal gammopathies of uncertain significance. And in combination with the other immunoglobulin subtypes within this group, there has to be less than 10% bone marrow infiltration. This tends to be lymphoplasmacytic in this instance, and also may be associated with one-strong macroglobulinemia in due course, and there needs to be no evidence of anemia, constitutional symptoms, hyperviscosity, lymphadenopathy, or hepatosplenomegaly. So essentially, it's a kind of precursor phase that may progress to full one-strong macroglobulinemia, and that's why the cells within this particular subtype are more lymphoplasmacytic rather than simply plasmacytic. Rarely these patients can go on to myeloma or chronic lymphocytic leukemia, and they may also have amyloidosis. So as I've said already, there's less than 10% clonal involvement by the plasma cells. They are either lymphoplasmacytoid or showing plasma cell differentiation. So they do express CD20, obviously surface immunoglobulin M, but they're negative for CD5, CD23 generally. That's also commonly seen in lymphoplasmacytic lymphoma, which can arise from this. And also, interestingly, the MYD88 mutation can also be present at this stage. That again is common in patients with Waldenstrom's macroglobulinemia due to lymphoplasmacytic lymphoma that this may progress to. Most cases of monoclonal gammopathy of uncertain significance, however, are non-IgM. They're mainly either IgG or IgA.
Apologies, guys. I've just discovered that there was no sound on that screen recording. So if you bear with me for one moment, I will share my screen again and we'll get that recording started again from the beginning. Apologies about that. And I think there was an issue with messaging in the chat as well. So thank you while you bear with me for just one more moment.
Well, good evening and welcome to this session on plasma cell neoplasms. I'm sorry I can't attend at this time, but I hope this recording proves useful. Essentially, this will be a repeat of the lecture I gave last year. A little has changed in the world of plasma cell neoplasms. And I'll give an overview of the area and then go through some illustrative cases. Thank you. So this is the WHO 5th edition classification of the plasma cell neoplasms. Interestingly, you'll see that monoclonal gammopathy uncertain significance appears to be absent in this list, but I've included it in the presentation because it's really an important part of diagnostic work. The plasmacytomas, either solitary or extrasolitary in bone or extramedullary, are relatively uncommon, really a diagnosis of exclusion, having excluded a multiple myeloma. In terms of the plasma cell myelomas, you see they're split into plasma cell myeloma, which is either smouldering, non-secretory, or plasma cell leukemia. And I'll go through the definitions of each of those as we go along. But really, the distinction needs to be made between a plasma cell myeloma and a multiple myeloma. And that is based on on a combination of clinical features and morphological features. A lot of people don't really make that distinction, but certainly within a hematological practice, that distinction is important. Finally, I'll touch very briefly just to mention really the POEM syndromes. This is a clinical correlation, and the role of the histopathologist or hematopathologist who are reviewing bone marrows is really just to give the plasma cell features within the marrow that can be associated with other clinical features to make those various neoplastic paraneoplastic syndrome correlations. So starting off with the monoclonal gammopathies of uncertain significance, you can either have IgM monoclonal gammopathy or non-IgM. So the IgM stands out as a specific group. It's just 20% of all the monoclonal gammopathies of uncertain significance. And in combination with the other immunoglobulin subtypes within this group, there has to be less than 10% bone marrow infiltration. This tends to be lymphoplasmacytic in this instance, and also may be associated with Waldenstrom's macroglobulinemia in due course, and there needs to be no evidence of anemia, constitutional symptoms, hyperviscosity, lymphadenopathy, or hepatosplenomegaly. So essentially, it's a kind of precursor phase that may progress to full Waldenstrom's macroglobulinemia, and that's why the cells within this particular subtype are more lymphoplasmacytic rather than simply plasmacytic. Rarely these patients can go on to myeloma or chronic lymphocytic leukemia, and they may also have amyloidosis. So as I've said already, there's less than 10% clonal involvement by the plasma cells. They are either lymphoplasmacytoid or showing plasma cell differentiation. So they do express CD20, obviously surface immunoglobulin M, but they're negative for CD5, CD23 generally, and that's also commonly seen in lymphoplasmacytic lymphoma, which can arise from this. And also, interestingly, the MYD88 mutation can also be present at this stage. And that, again, is common in patients with Waldenstrom's macula anemia due to lymphoplasmacytic lymphoma that this may progress to. Most cases of monoclonal gammopathy of uncertain significance, however, are non-IgM. They're mainly either IgG or IgA, only occasionally E or D. Again, similar features, so a low serum monoclonal M protein of less than 3 grams per deciliter, clonal bone marrow plasma cells less than 10%, and absence of any end organ damage, so hypercalcemia, renal insufficiency, bone lesions, anemia, amyloidosis, etc. Can I get a light chain subtype? But that's really a clinical kind of diagnosis, and it doesn't really affect the marrow enumeration of the plasma cells. And again, of course, this can only be diagnosed in the absence of end organ damage. If there is end organ damage, it automatically moves it into either plasma cell myeloma or, dependent on the stage of that damage, and more usually a multiple myeloma. Just bear with me, it's a bit difficult flicking between screens at this whilst recording in Zoom, so just make sure I'm in the right place, please. Bear with me just for 1 second. Okay. So obviously the marrow, I've said they're clonal cells, so they're going to be light chain restricted. It can be difficult to assess the light chain restriction when the percentage of cells in the marrow drops. Obviously, you're going to have some normal plasma cells there as well. Typically, though, if you've got certainly, up to 5% or maybe even 3% plasma cells within a marrow, it's usually relatively straightforward to identify clonality with light chains if you've got good immunohistochemistry. You can do in situ hybridization if the immunohistochemistry is a bit equivocal or there's a bit too much background. Once you get down to 1 to 2% plasma cells within a marrow, it's actually quite difficult to demonstrate restriction by immunohistochemistry, and in situ hybridization might be the better way for that. But usually the level is between 5 and 10% anyway. So these are CD20 negative because they're not lymphoplasmacytic. They will be positive for MUM1, CD138. Don't tend to use CD38 on its own. A lot of people use CD56 to demonstrate that the cells are neoplastic. We don't tend to do that in our institution because the percentage, as we'll see later, are in fact negative for CD56. But if you've got good, I think good light chain restriction is a better indicator. There's also the question of looking at the ratio of the light chains. So you're allowed up to, some people say up to a 10 to 1 ratio of kappa to lambda, but really I think that 4 is the limit. I've heard 10 in some meetings, but we go for 4. Usually, if you're worried about a case, is it more than 4 to 1 kappa to lambda? Well, in all the cases that I've done where I've wondered about it and done a formal count, it's been within 4 to 1. So if there is restriction, it's usually very clear if you've got good immunohistochemistry, except in those cases where the number of plasma cells is really low. And I think in those cases, it's very difficult to tell on morphology whether you have actually got restriction. I think in those cases, it is acceptable to say that there may be skewing towards 1 or possible restriction, and then the clinicians can put that together with all the other features to determine whether they think that's an MGUS or not. The risk stratification is based on the M protein and the serum free light chain ratio, so that doesn't affect the reporting of it histopathologically. And importantly, the risk of progression to a plasma cell or multiple myeloma is 1% per year cumulative, which persists indefinitely. So the longer you've got it, the more the risk of progression. And whereas the IgM form will progress to usually Waldenstrom's macula anemia, this is progressing to plasma cell or multiple myeloma. usually identified incidentally, and then the patient will have to undergo a bone marrow and for blood count and so on, maybe some genetics. It may be associated with other immune diseases, so glomerulonephritis, lichen myxodematous, necrobiotic xanthogranulometer, and also rarely with a peripheral neuropathy. But these don't come under the umbrella of end organ damage, so they don't move it into a myeloma. Because what we're really, of course, multiple MGUS is becoming more and more common as people are screened more, and it's identified incidentally, and then of course they undergo long-term follow-up because of the risk of progression. But clinically, what's most important is plasma cell myeloma. So obviously, it's a monoclonal expansion. So these are post-germinal center cells. They express immunoglobulins. They're called the M proteins or paraproteins. And you get serum paraprotein. They've got a range of, they've got a uniformity of morphological and immunological features. And clinically, they usually behave in a similar fashion. And that's why it's still classified as a single entity. Now, in contrast to the myelodysplastic syndromes and acute myeloid leukemias and B-lymphoblastic leukemias, where cytogenetic abnormalities are becoming primary for the diagnosis of different subtypes, where the different cytogenetic subtypes occur within myeloma, they are stated as prognostic features or taken into consideration as prognostic features, but they're not separating them out into different entities. That may change in later editions of WHO, of course. Bit of a wordy slide, I'm afraid, but just to tell you a bit about plasma cell myeloma. So obviously, it's based in the bone marrow. It's important to consider the size of the sample because it can usually be patchy. Well, it is almost always patchy unless you've got a really high level of marrow involvement, which will probably move it into multiple myeloma. So it's patchy disease, and therefore establishing, first of all, its presence, and secondly, the number of cells, which are obviously important for its classification into either an MGUS or plasma cell myeloma or multiple myeloma. It's important to consider the size of the biopsy. So if it's only a few marrow spaces, say less than five, you've got to put a bit of a health warning that the percentage might not be representative of the marrow overall. Also take into consideration the fact that the number within the marrow may be different to that in the aspirate and in flow because of that patchy nature of the disease. So multiple myeloma is where you've got a plasma cell myeloma, so greater than 10% plasma cells plus end organ damage, or in the absence of end organ damage, laboratory or imaging findings that suggest risk of developing end organ damage, and those are down at that bottom little bullet point. So specifically, the International Myeloma Working Group has identified a plasma cell bone marrow percentage of greater than 60%, a ratio of involved to uninvolved serum-free light chains of more than 100%, or more than one focal bone lesion of greater than 5 millimeters in size, as indicators of imminent development of CRAB end organ damage. And so if those features are present, then plasma cell myeloma will turn into a multiple myeloma. And for the purposes of histopath reporting, the important thing there is the bone marrow percentage of plasma cells being more than 60%. The clinical behavior is highly heterogeneous. They all evolve from an asymptomatic pre-malignant stage, so they do arise from monoclonal gammopathy. There may be a smouldering myeloma before they become a full-blown plasma cell myeloma or a multiple myeloma. And of course, a lot of patients with plasma cell myeloma also have evidence of multiple myeloma. So the two are used synonymously, but technically they're slightly different. Plasma cell myeloma would be without the end organ damage, multiple myeloma, the same thing, but with end organ damage. Usually, once the percentage of plasma cells goes, much more than 25% in the marrow, you've usually got some end organ damage. So you can't diagnose multiple myeloma just on the marrow, but you can. It's most likely to be there clinically. What do? Well, I don't try to preempt the classification clinically overall with the marrow. I'll often, unless it's clear, either an MGUS or multiple myeloma, because 60% I'll say it's plasma cell dysplasia and clinical correlation is required. Of course, an MGUS with end organ damage, that becomes a multiple myeloma. So what we've got is an M protein, mostly IgG, followed by A, D, E, and M are less common. A very small number have non-secretory disease, and in 90%, the normal immunoglobulin is reduced, so the patients have an immune paresis. They may also have hypercalcemia, raised creatinine, or hypoalbuminemia. So it's relatively, it's not in the top 10, but it's the 14th most common. And the incidence has been going up for the last 30 odd years. And this is specifically driven by increase in low and middle income countries. Now, that could be due to change in demographics, change in their burden of disease, particularly in some regions where malnutrition and infectious diseases are becoming less, well, not less common, but certainly a lower course of mortality, but also just increased detection, I think, in many of these countries as well. So, as of the WHO in 2024, it was considered, multiple myeloma was considered incurable. So approximately 50% survive in 5 years. But there is a really massive increase in new treatments in this area. Patients now having transplants for this. That wouldn't have been the case 20 years ago. And so the overall survival is generally increasing quite well in this area. Though it's important to remember it is still overall incurable, and most patients will respond well to the first round of treatment and usually get a relatively good remission. But then when it recurs, it usually recurs quite aggressive. The prognosis has been established by the international staging system and then refined by the addition of genomic abnormalities, either in the revised international staging system or the international myeloma working group, and I'll show those later, just in detail. But essentially, the genetic abnormalities seen as high risk are T4-814, T14-16, deletion of 17, and amplifications or gains of 1q21. So cytogenetics is important. Those with a deletion of 17p have got a worse outcome. Deletion of 1p32 is another emerging poor prognostic marker. Historically, T4-814 was considered high risk, but there are new inhibitors for this group, so it's not so bad now. And again, BCL2 inhibitors have increased the response rates in patients with 1114. So this is the prognostic staging system. So you can see that the international scoring system, staging system rather, is based basically on the serum beta-2 microglobulin, serum albumin being below or above a certain level, with an intermediate risk category where those levels aren't fulfilled. Both the revised ISS and the International Myeloma Working Group are essentially the ISS plus different combinations of cytogenetic features, of which deletion of 17p and T414 are the most prominent. The International Myeloma Working Group, not including the T1416. I don't think that's right. I can't see from this slide that that's right. Right, so it seems like the most important job we have to do as histopathologists in a marrow is to first of all say whether the biopsy is adequate. Secondly, to say how many plasma cells are there, and you would think that that would be a simple thing to do. We do it in quite a subjective fashion by eyeballing across the marrow, and there are reasons for that. First of all, if you only counted 500 cells or even 1,000 cells in one area, that would be no way representative of the whole marrow, whereas if you do it in an aspirate where the whole thing is being diluted up, then it should be representative. So we have to eyeball it across, and you can see, even in a test set of cases, very wide variation of the number of counts of cells given by pathologists as percentages, either using CD138 or MUM1. The important thing, though, is that the variance is much lower with MUM1. This is because it's nuclear and the stain is usually a lot clearer, can be cleaner. Also, CD138 is cytoplasmic, so it's bigger. So it just looks a greater percentage of the area. I think there is a role for digital pathology counting of this. But in essence, the most important thing to establish is, does it look like it's under 10%? Does it look like it's over 60%? Or is it somewhere in between? Because those are the essential cutoffs. But it's important, I think, to do MUM1 and CD138. I suppose you could argue that of the two, you're going to dispense with one of them, then I'd dispense with CD138, because MUM1 is the most accurate stain for this. And then in terms of establishing clonality, instead of using CD56 and so on, which isn't positive in all neoplastic cells, I'd concentrate on getting good immunochemistry for kappa and lambdas, supplemented by in situ where necessary. So this is the positivities to show whether a cell is neoplastic or not. So you can see that 19 is lost in an abnormal plasma cell. We don't tend to do that. 20 can be positive in an abnormal plasma cell. Again, we don't tend to use that. This one you see, a lot of people hark on about this, but essentially 15% of CD56, 15% of 25% of abnormal plasma cells are going to be negative CD56. So that is not helpful, in my opinion. This is the range of cytogenetic abnormalities, and so you can see here the 1114, which is obviously cyclin D1, relatively frequent, probably one in about 7 to 8 cases, and that has importance for prognosis. So this group here, group A, is cyclin D1 positive, and that has a better outcome, and that may respond to inhibitors against cyclin. Smoldering myeloma. This is kind of smoldering multiple myeloma, so there's a pre-form. This is where you've got a monoclonal protein over 3 grams, urinary monoclonal protein over 500 milligrams, no myeloma-defining features or amyloidosis, and clonal plasma cells 10 to 60%. Multiple myeloma, however, is where you've got clonal plasma cells greater than 10% and a biopsy proven extra medullary mass, and end organ damage. And it can be any of these, often bone lesion, but of course, if you've got one of these, you've got a bone lesion anyway. Or you've got clonal plasma cells greater than 60%, that's usually what you have. Or serum-free light chains greater than 100, or focal bone lesions, more than one focal bone lesion on MRI studies. Obviously, these two at the bottom, you can't assess histologically, but clonal plasma cell percentage greater than 60%. Plasma cell leukemia, where you get greater than 5% circulating plasma cells in the peripheral blood. Again, as in all of hemopath, correlation with the aspirate in the peripheral blood is vital. Just mention the three paraneoplastic syndromes. Most commonly, this is POEMS. We get polyneuropathy, organomegaly, and endocrinopathy, skin changes. Then there's also TEMPI with telangiectasia, high red blood cell count. So if you've got high hemoglobin, you might consider that. And then ASOP syndrome, which I can't really see a case of, to be honest. A lot of people now are getting, increasing treatments for multiple myeloma, and so people are beginning to develop second malignancies after chemotherapy or transplantation or radiation. So that's something to consider in, as people with myeloma live longer, they are now becoming at risk of second malignancies. Right, so I've got a few cases, or probably more than a few, and for each one, I'll just some illustrative features really, because in terms of the actual morphology of MGUS, plasma cell myeloma and multiple myeloma, there's little to say beyond identifying plasma cells. The one thing to say, I suppose, is that plasma cells can be quite variable in their morphology. Usually they may look like small normal plasma cells, but quite often they look like larger cells. You might have plasmablasts. You may have lymphoplasmacytic plasma cells, particularly in that IgM MGUS. And also after treatment, when you're considering follow-up of marrows with patients who've been treated either by transplant or chemotherapy, the plasma cells that are left behind are often quite abnormal and might not look like typical plasma cells. So in that case in particular, it's really vital to do the immunohistochemistry, or you won't be able to distinguish them maybe from left-shifted myeloid cells in a post-treatment marrow, and so on. Anyway, case one is not actually a case of myeloma, but it is a case of lymphoblastic leukemia with aberrant CD138 and CD56, and the TDT was weak. So in this case, if it hadn't been considering other features, because there was no serum paraprotein and the serum free light chains were not increased, it might have been diagnosed as myeloma just on the basis of the histopath. So 61, worsening back pain, and then had a spinal biopsy reported as lymphoplasmacytic lymphoma, and then had a marrow taken. Hemoglobin a little bit low, platelets were okay, white blood cell count was okay. So this is what it looked like. A bit of a scrappy biopsy at one end, but quite good where it's not been hemorrhagically diluted and broken up, markedly hypercellular in this area, and a higher power in these area. These cells, they don't really look like plasma cells. These look more like lymphoblasts. But as I said earlier, plasma cells can have quite a variable morphology. So just because the fact they don't look like typical plasma cells doesn't mean to say it can't be plasma cell neoplasm. And this one in particular here, that does look like a plasma cell. That looks like a plasma cell. There are focal plasma cells in here, so still have to consider it. It was positive for CD79A. It was focally positive for CD138. It showed strong lambda light chain expression, which was restricted versus kappa. There are some isolated normal plasma cells here. It's important when you assess light chain restriction to look for strong cytoplasmic staining within the cells and ignore all the stuff in between, which is really just serum immunoglobulin, which has been left behind from the normal complement of antibodies that are in the bone marrow before it's taken out, fixed in formalin, and put in a paraffin block. and it was positive for PAX5. So that would again be uncommon in myeloma. TDT was weak in this case, bit of a wishy-washy stain, but you can make out that it is nuclear staining. So just because something's CD138 positive and shows light chain restriction doesn't mean to say that it's right. Case 2, 71-year-old woman in a trial. So she's anemic and thrombocytopenic, platelets 92, and she had a very dense infiltrate of plasma cells with a very wide range of maturation in this case. And there was also some bone irregularities. So this is it overall. So obviously for a 71-year-old, this is massively, almost maximally hypercellular with only a few marrow spaces left. The bones here do look a bit ragged. Difficult to see at this power, but this here looks resorbed, and up here it's resorbed as well. It's always important to consider the bone in bone marrows. My first academic work was in bone biology, and the bones are important. So here, lots of cells with abundant eosinophilic cytoplasm, prominent nucleoli. Not all of them with an eccentric nucleus, but many of them, if you look carefully, have got an eccentric nucleus. And I think granular eosinophilic cytoplasm together with a kind of slightly stippled and eccentric nucleus is the most important feature for defining a plasma cell. I must confess, and I may be wrong, but in looking at hundreds of these cases, I've never really been able to convince myself that there's a clock face. I think what they mean by clock face is you've got some granularity in little spots in the marrow, but I wouldn't call it a clock face. So I tell people, and you may all disagree, of course, don't go looking for clock faces because you'd probably be disappointed. Look for granularity instead, both within the nucleus and in the cytoplasm. The cytoplasm has this faint granularity to it, and the eccentricity of at least some, if not most, and in classical cases, all of the plasma cells. So here we've got large numbers of abnormal cells that look like blasts, prominent nucleolus, large nucleus, and eccentric placed nucleus. And here they are, higher power. So granularity, I suppose that's what people mean by the clock face, eccentrically placed, and this granular kind of cytoplasm. So, and also the cells kind of merge into each other, which I think is a combination of the granularity of everything. And so the whole thing to me looks a little bit blurry, and that's not the way it's been photographed or imaged. It's because there's a lack of clear distinction both within the cells because of granularity and between the cells because they're absolutely opposed to each other. So when you see even at low power this slightly wishy-washy, slightly blurred appearance, as if someone's drawn it in pastel crayons and then smudged the whole thing, which is something that I look for, then that is an indicator at a macro level or high power, low power level of what's going on in this high power. So you've got some blast-like cells, really big blast cells, and you've got some more smaller, more typical plasma cells. Okay, but otherwise the percentage is quite clear. It's going to be multiple myeloma. Case 3, 75-year-old man. This patient, query myeloma. So at 50% plasma cells, but they're non-secretory. So here they are. So it's massively filled in by an abnormal infiltrate. You can see that even at this power in a 50-year-old. Cells are atypical. There are many, though, with eccentric nuclei that could fill the bill for plasma cells, but we haven't got an increase in light chains. CD20, however, was negative, so that would be the other thing that you might consider in this area. And CD138 was very, very strongly positive. So non-secretory, so no immunoglobulins, MUM1, again, very prominent. And you can see here, you probably estimate this area here in particular as a higher percentage than this area here in the MUM1. And that's why you give a higher, people tend to give a higher percentage with CD138 than MUM1. Interestingly, in this case, kappa was just positive in this area, and all this area was negative, despite the fact that it was strongly MUM1 positive. So you kind of ask the question, well, maybe this is one of these biclonal lesions, and this could be positive for lambda, but it was negative for lambda as well. The whole thing was negative for lambda. And then we went on to in situ in case, expressing it by in situ. This was the in situ for kappa. So again, patchy and many areas that were negative, despite being clearly 138 and MUM1 positive, and negative for lambda as well. So non-secretory, and much of it not expressing immunoglobulins even by immunohistochemistry and in situ hybridization, but clearly, you know, abnormal proliferation of plasma cells. So this would be a myeloma. Case 4, 62-year-old male, raised immunoglobulin, large paraprotein, low serum free ratio, but extensive lytic lesions, so that will push it into multiple myeloma category. So plasma cells are low, but the fact you've got these lytic lesions, and there was also a nodular pattern built from infiltration within the marrow, supported diagnosis of myeloma rather than MGUT. And in this case, what I would say is I'd state that the cells are low in the marrow, so they're restricted, indicate that it's patchy disease, so it might actually be higher in the bit of marrow just next to it, and that clinical correlation is required. So this is it here at low power, so patient born 62. So I think this is at least moderately hypercellular for some of this age. Some of these marrow spaces are a bit disrupted, but where they're nicely intact, this is definitely hypercellular. And when something's hypercellular, you've always got to ask, why is that the case? Is it reactive? Is there something in there? And so on. So obviously not normal because it's hypercellular. They're good at higher power. So we have got some plasma cells like there, there. So you've got to look at it carefully. When it's down, when the percentage is down under 10%, you have to look carefully to see the plasma cells. But you'll still see them like there, there. That's a plasma cell there. So and there. So when you get your eye in, you can see them relatively easily, particularly if it's a dispersed area like this. And the 138 indicated that they are present both in a nodular distribution and in an interstitial distribution. And I always say whether it's interstitial scattered infiltrate or a nodular infiltrate, and nodular infiltrate it tends to be worse. And you should also always do a reality check between the immunohistochemistry and the H&E. So if you see more on the immunohistochemistry, it could be because they look atypical after treatment or for some other reason. But always go back to the H&E and say, right, now I know where the plasma cells are. Can I convince myself on the H&E that that is appropriate? The answer is almost always yes. It's not that you've missed them on the H&E, it's just they were difficult to see on the H&E for a whole range of reasons. But always reality check backwards from the immunohistochemistry once you get it. And if it doesn't reality check back, then ask the question why. You know, as in that first case. So here we have lots of plasma cells. This is they're not lining up along blood vessels, so they look, even though the number's not high, it's an abnormal distribution. If it was reactive, you'd expect at least some of them to be lining up in nice lines along blood vessels. And then there's nodular areas here, which are clearly abnormal. It's not so much the case as with the lymphomas that you have to that a paratrabecular infiltrate of plasma cells indicates neoplastic clone. They don't tend to be paratrabecular really, whereas that distinction is really important for lymphomas. for plasma cells, it's really all down to light chains. Right, case 5. This is relatively straightforward, unfortunately. A 66-year-old woman, 80 to 90% of the cells. Well, it is well over 60%. So that's, it doesn't really matter whether it's 80 or 90%, it's over 60%. It's only important in that if you treated it, do you want to see it coming down? But they measure that with the paraprotein anyway. The interesting thing in this case is that it's extended into the periosteum and associated skeletal muscle. So very marked proliferation of relatively typical plasma cells everywhere. And here it is in the periosteum, and there's also skeletal muscle in here as well. So it's infiltrated out of the marrow. Something we don't tend to see that commonly, because I think cases in this country are diagnosed more quickly. Certainly some of the work that I've done sub-Saharan Africa, this is a more typical presentation of myeloma. People living in the bush, a couple of 100 miles from the city, never to go to the city, they usually present with something that's really bad. Diagnosis of myeloma usually straightforward. I don't think they see any else. Case 6, query myeloma. So quite high kappa light chain, high paraprotein, slightly anemic, platelets, yeah, kind of not too bad. Neutrophils is okay. And this one didn't fulfill the criteria for multiple myeloma, but did for plasma cell myeloma. This is it at low power, so so 79-year-old. So probably normal cellularity actually. When you look at it, yeah, it looks a bit busy. Lots of hemorrhage in it, which is making it all serum, which is making it a bit difficult to interpret. But even so, these cells all look a bit pink and a bit wishy-washy. Obviously, the erythroid cells are nicely clear, but everything else just looks a bit pale and washed out. And that, I think, is a consequence of most of the cells in here actually being plasma cells. So when you go back to look at it and say, yeah, okay, all these small little cells, these are all plasma cells, and that's what the CD138 showed. Case 7, this was really taken because they suspected amyloidosis. 20% increase in plasma cells, showing lambda, and some thick-walled blood vessels. I apologise not able to show the birefringence, but I just want to make a note that we frequently want to know whether there's amyloid. By convention, in our hospital, we've got a very big renal unit here. We don't tend to look for amyloid unless the clinicians ask for it. But it is an important feature, particularly as it does change the classification, because if you've got amyloidosis, then you've got end organ damage, technically, and it moves into multiple myeloma. So here we have a thick blood vessel. So this, you do have to look very carefully through the marrow to find the blood vessels, and then to look at them to see if they've got any thickening. And here we've got nice Congo red staining in the blood vessels. This is pinker than what you've got in the collagen here, which is a bit more orange, and this was up at the birefringent. Cases now. So case 8, 75-year-old woman with an IgA paraprotein, and she's got 40% plasma cells. And the reason I show this one is got nice Dutch bodies here, these intranuclear inclusions paraprotein. So just 2 nice Dutch bodies there. And the final case, 71-year-old female with a plasma cell neoplasia, only 10 to 20%. And this patient had these foamy MOT cells. Finding Dutch bodies and MOT cells is interesting and potentially important, but it's not actually part of classification. I think it increases the risk that it's neoplastic, but prominent reactive populations, which can be up to 20% plasma cells, can easily have collections of hemoglobin in them as well. So that's the last case. So I'll stop the share now.
Fine. which has just finished probably about 20 minutes ago. But I'm available for any questions that the audience may have about myeloma. And thanks for facilitating the session, Emily.
No problem. I think everyone should be able to use the chat or the Q&A to ask any questions that they have.
Okay. I mean, I must say it's always a little daunting to give a talk about myeloma because sometimes I find it difficult to say anything about myeloma, but it's a common disease and it's important to consider it and important to consider percentages of plasma cells, whether it's part of an MGUS, plasma cell dyscrasia, a plasma cell myeloma or a multiple myeloma. And I outlined all of those things in the talk with the different percentages of plasma cells to be considered, the presence of absence of any end organ damage. This talk will be available through the Diagnexia site. First of all, I think, Emily, we should be able to send it out to people by email, the link to it. I believe that's been happening.
Yeah, exactly.
Yeah, and also it'll be available on YouTube in due course. So I don't know if there are any questions. I always, when I was asked to give that talk on myeloma, I kind of thought, oh, what am I going to say about myeloma? But as you can see, I did manage to talk about it for about 50 minutes. So there is, in fact, quite a lot to be said about it. And I think it is important to emphasize to all the audience that just because a disease is relatively common and we think we understand it well, it's still important to look into it. So great question there from Mabuji. Which marker is better, CD138 versus MUM1? So we did also used to do VS38C, but we abandoned that in our laboratory because it also stains myeloid cells. So it's very difficult to distinguish it from plasma cells. A lot of people say it's good to use CD56 because that's positive in abnormal or neoplastic plasma cells. But again, that's not universally the case. That's not usually universally the case. So we rely now on MUM1 and CD138. I would say MUM1 is the better marker. You've got to look more carefully because it's nuclear and so it doesn't highlight itself as clearly to yourself when you look at it down the microscope. 138, as I indicated in that slide in the talk, often gives quite a high degree of overestimation. So MUM1 is a much cleaner marker. So if I was going to go for any, if I was forced to do 138 or MUM1, I would do MUM1. Routinely, as I say, we do both still in our laboratory. I usually look at the 138 and think, oh, this is going to be about 30%. Then I look at the MUM1 and think, no, it's only 20% or 15%. So in a way, you could say the CD138 is redundant. Also, MUM1 is a more specific marker as well. Though, of course, MUM1 can also be positive in some B cells, particularly some of the high-grade lymphomas can be positive for MUM1. So, you've got to have a plasma cell marker in there. And CD138, though it's also expressed in epithelial cells, it's not expressed in B cells. So I suppose, there's still a rationale for having the combination. Yeah. Any other questions?
Don't see any others coming through.
No. Hopefully it was a useful talk. I mean, I've given it a couple of times now to the Association of Clinical Pathologists, so I should recognize that this was initially developed for them. People find it educationally interesting. I know that from the feedback that I've received. As I've said, I've always thought, well, what are people going to get a gain from a talk on myeloma? But like I say, it's a relatively common disease, an important subject. I remember when I was a medical student and we were placed on the asthma rotation, and as a medical student, I thought that wasn't very exciting. But as the consultant pointed out to me, asthma is a common disease and very important. So it's always important to remember the common things and do them as well as possible. Okay. I'm still around. Any other questions? Otherwise, it's back to full-blown activity next week. So this is really to whet your appetite and to get you back in the swing of things after a short summer recess. It'll be Dr. Patrick Shengarai, who's actually from Zimbabwe, trained there and been a colleague of mine in Manchester for 20 plus years. He is certainly a nationally renowned expert in soft tissue tumours in the UK. So please, as many of you as possible, join, and feel free to share the link with your colleagues. Patrick is a great teacher, a great colleague. What he doesn't know about soft tissue tumours is probably not worth knowing. So, you know, he's a real star performer. And soft tissue tumours, they occur everywhere, all over the world, and they're a poorly understood subject unless they're presented well by an expert. So please tune in same time next week. And we have a full program all the way through till just before Christmas. And then we already have the program already in place, bar, I think, 2 slots right the way through to the end of next July 2026. And thank you again for all your attendance, and to Diagnexia for their continued and very valuable support of the program.